So, just over the next 20 minutes or so, I'm just going to talk to you a little bit about rare leukodystrophy. So, I'm one of the leukodystrophy clinicians in Manchester. And I think the first thing to say with a lot of people when they are referred to our leukodystrophy service is, do you actually even have a leukodystrophy? And it sounds funny, but actually a proportion of patients who are referred to our leukodystrophy service do not have a leukodystrophy. And sometimes we are untangling a mess that the family is in because, for example, this first family referred to us to a leukodystrophy service and ended up having a tumor. So, these kind of things can happen because a lot of things can mimic leukodystrophy. The second child, you hear this again and again in this meeting, this child had MS, and a lot of patients with multiple sclerosis and inflammatory conditions can look like a leukodystrophy and get referred to our service. And then you've got a true child or adult with leukodystrophy who's referred to the service. So sometimes you're referred to a leukodystrophy service and then down the line we're telling you that actually you don't even have a leukodystrophy. And then being tasked to talk about rare leukodystrophies, as families in the room, you will know that there is no such thing as a common leukodystrophy because all diseases which are leukodystrophies are rare. So the UK government defines rare diseases as less than 1 in 2,000. And to give you an example, XALD, which is one of the commonest leukodystrophies we see, is like about 1 in 30,000 or so. So that is already a rare disease. So there are things which are rarer than rare in leukodystrophy and in rare diseases. So we've got ultra-rare disorders. These are medical terminologies we sometimes use. So these are when conditions are less than 1 in 50,000, and then even hyper-rare disorders now being reported where you might be one of the only few people in the world, and therefore there's not much in literature. And you can imagine that this can be very stressful for parents, patients, and families dealing with a leukodystrophy. And the first thing is, can we just deal with the rare disorders? So, what is between 1 in 2,000 and 1 in 50,000? Are we comfortable in the UK that we can deal with that before we talk about the ultra-rare? And many of you, of course, who are here will know that we have got these inherited white matter disorder services in the UK, and this has been there really for now 2.5 years or so. So you would think that, therefore, it should be all up and running, people are referring into the service, and everything is running smoothly. But from the case examples, you'll see that that's not actually the case, and there's still a lot of lack of awareness about the service. This is to give you some examples. So the first case of a 10-year-old boy referred by the GP with lots of ENT issues, so referred to the ENT team as well as pediatrics, saying lots of problems with his nose and getting blockage with his nose. But then, obviously very concerning, significantly, there is a small paragraph in the referral which says that there's been some concerns in school about behavior, declining in school behavior and sort of isolating. And of course, that is very, very concerning. But this was just sent as a box standard outpatient referral to ENT and pediatrics from the GP. And when the pediatrician eventually saw the child and delved into this child had lost a lot of skills, could play cricket 2 years before that, and now has lost that skills, cognition has been deteriorating, and unsteady on walking. So lots of changes has happened over time. And on the first scan you can see, which is a CT scan, there is this deficits of calcium that you can see, which means that there's probably been some damage there already for some time. And when an MR scan is done, you can see a very florid change here. So this change here, which you can see, this bright whiteness that you see, is the leukodystrophy, it's a change to the white matter. And in this pattern, it's very, very classical of XALD. And you can also see when they injected some dye, contrast, you can see it lighting up. So this is a case of XALD, and we've understood XALD for decades now. There's scoring systems on how we can actually score an MR brain scan to judge how severe a child is and what treatment options there are. So in this case, the diagnosis was made with genetics, the scoring was done, and a score of generally more than 9 tells us that that child is going to be ineligible for transplant. So that means we are stuck because, all these decades we've had transplant and now we can't do that for children and adults. But things have progressed over time, and just so that you don't miss out what's happening next door, there are treatment options now which are being thought of. And there's a compassionate access program for children and adults with ALD to access levetiracetam, which is a medication which tries to act on a pathway. It's very, very complex, but the drug basically blocks a pathway here which causes inflammation or swelling to the cells, which causes the damage. And the theory behind it is if you can block that, you can slow down the progression in this condition. And the trial which was done in children was done over almost a 2-year period, and in the children that they recruited, they found that a lot of them did not progress with the condition compared to the natural history, which of course is promising. And this is not a treatment on its own, but the thought in the future could be that this can be a bridge to transplant, that if you can slow down the condition, you could then eventually transplant the children or adults and stop the disease progressing. So this is still in very early phases, and the only way to access this at the moment is via our team in France, and that's a compassionate access program. So it's on a ask-by-ask basis and making sure that the child is in the eligibility criteria. You heard a little bit about trials earlier from Nina. This is slightly different. This is a compassionate access program, which means that, that it is done where the drug is given for free, but the families have to fund the travel to France. And I think the learning point from that is, we've understood XALD for decades, but actually we don't, because there are still bits of XALD that we're trying to understand now. We're trying to use alternative kind of therapies to try and stop a disease, which in the past, there was a cutoff, clear cutoff that we knew that when you score on an MR scan, if it was higher than that score, there was nothing we could do. But now, crossing international borders is really important to try and raise that awareness. And you could see in that case, the diagnosis could have been picked up, even quicker if, the GP was alert, pediatricians were alert and thinking about this. So getting the message out there is really important. Second case is to give you an example of an ultra-rare disorder. So this is an 8-year-old girl who was previously well, and then a little bit of unsteadiness seen by the orthopedic team, thought to be maybe a problem with her feet, but then discharged. Seen again at the age of 5, and they were thinking about doing a scan, but then suddenly she had just a minor bump to her head, and she went off legs. And she has a scan which, again, you can see a lot of these changes in her white matter here, so a different form of leukodystrophy from the other one. But also, strikingly, you can see these little black holes, as we describe it, and those are cysts or holes, which means that that leukodystrophy is causing damage quite fairly quickly. And this child changed overnight after having a trivial head injury. And interestingly, her younger brother, who was 3, also had some unsteadiness. So this is a really ultra-rare disorder called vanishing white matter leukodystrophy, which can happen in children, particularly triggered by the stress pathway that we have in our brain. So we all have what is called an integrated stress pathway, which protects us from things like fever, stress, shock, a minor bump. But in this condition, that stress pathway is not working. So if you have a minor head injury, you have stress or fright, you can suddenly just start damaging your white matter. So these kind of things are obviously very scary, and up until now, there wasn't any treatment for a long time, and these children unfortunately progressed like many leukodystrophies, and in vanishing white matter leukodystrophy, it's a particularly aggressive form, and many children die within a few years. They don't even make it past the first decade. But now there are lots of trials being done by our colleagues in Netherlands, where they described this condition only about 15 to 18 years ago. And this medicine is basically attacking that stress pathway to say, can we dampen down that stress response? And they had 2 drugs, one which had been recruiting up until 2024, and then now a new trial which has just opened up in Amsterdam. And this is just from this summer. And I guess the learning point from here is that we really have to keep up to date, even as clinicians, because things are changing across the world. It's not really thinking about how we can manage things in the UK. For these ultra-rare disorders, we have to cross international boundaries. We as clinicians have to be collaborating with our colleagues and really keeping up to date. And that's where these rare disease networks are really helpful. Many times as families with children or colleagues or adults with rare diseases and leukodystrophies, you may feel that you are really alone, and sometimes you are going out there looking at charity websites and you're telling the clinicians about potential trials. And that happens because these are really rare diseases. And sometimes there are trials in very specific disorders with very specific gene alterations that before the clinicians hear, that families may hear because you are in that particular group. So it's really important to know that keeping that open communication between families and clinicians all the time to say, have you heard about this trial in the US or Amsterdam? And if we haven't, we'd probably link up with the clinicians there. Sometimes it may be very early phase things and it may not be coming to the UK as yet, but it's just helpful for that communication to be kept open. And to give you a flavor, this is just some of the things we see in our Manchester leukodystrophy service. And this is just scratching the surface because there are over 100 genetic white matter disorders. And I can't even tell you that these are common because many of you in this room here are families that we look after with the leukodystrophies here, and you know that these are not common conditions by any means, and that there are very few patients with this across the world. And the problem is complicated that within that condition, there's such a wide variation. You may have two children with the same condition, you link up with another family across the ocean, and they tell you a completely different story about how their child presented. There might be some similarities, but then lots of different changes about the symptoms and the signs that they experience. So I think, the learning point here is that these leukodystrophies are all very rare. You live with them, and we are trying to help support you and network you with clinicians across the globe to try and better understand this. So that was just for the rare, 1 in 2,000, but what about the ultra-rare and hyper-rare disorders? So these are the ones, as I told you, some of them are really, you might be one of the only 2-3 people in the world with that exact genetic mutation. And that is really hard. It's hard for everyone. It's hard for you as a family. It's hard for us as a clinician. It's hard for Alex DLC as a charity to support you because, like Dr. Green and others have said earlier, we can give you generic information about leukodystrophies, how your child or your family member is when we look after them. But when there's very little known in literature, it becomes very, very tricky. To make things even more difficult is when you have two children with the identical genetic mutation. You'll say, this genetic mutation is exactly what this other person somewhere else in the world has. And there are some variations in them. Someone will have some problems, the other one will have different problems, and the initial problem can be very, very different. And I think the reality is that this understanding of these rare diseases can only get better over time. And a lot of you, as you know, linking up with charities and other families, that networking, that understanding, and creating a database for all these patients is really, really important. And that support network, I can't, I'm glad to see so many, families here, and I think that kind of support network is crucial. Even if you don't have the same condition, you are still, in that pool of inherited white matter disorders, a genetic leukodystrophy, and that, having that support network of how this is difficult, as a family, navigating the stress, and sometimes feeling that you are doing all this work, which is the reality, because you have a rare disease or your family member has a rare disease and you're going to put all your efforts to try and understand that better and better. And the people working around you have to try and work around this to try and understand this better. But a lot of you will know that when you see a general pediatrician, a community pediatrician, they will not have ever heard about these rare leukodystrophies. But what a lot of families tell us is that what they want is for them to at least try to understand this, make an effort to say, right, I have not heard about this condition, what can I do to understand this better? So then when we talk about rare leukodystrophies, the first question we get asked is why, if there is a therapy available, why is it that some family members are getting it and some others are not? And that is always very, very challenging with rare leukodystrophies because sometimes there is a licensed therapy available somewhere in the world. But there are very, very strict kind of criteria many of them because they've got that from trials. So a big trial has happened internationally to say that these children or adults are going to benefit from treatment. The other ones are sort of excluded. So when you heard earlier from Nina talking about inclusion-exclusion criteria, that happens because there are very certain things that we know from trials that if children or adults get that, they may not get better or they may get worse. And we really learned that from our experience in delivering gene therapy for MLD, which some of you may know is one of the commoner leukodystrophies, metachromatic leukodystrophy. And when we initially set this service up, we were one of 5 centers internationally giving this. So we were getting referrals from all over the world, and it was really hard because in the first year, we had over 30 referrals globally, and only 3 children in the first year were eligible for treatment. So that's telling you that only 10% of the referrals of this rare leukodystrophy could even get treatment. And that tells us that, you know, the criteria has to be strict from the trial because we learned that when we went out of criteria, not just that it was not helping the patients, but actually it was causing harm. So the scary thing that we learn about this kind of rare diseases and the treatments that we are doing is that potential treatment, potential genetic therapies not just may not help, but it could potentially cause harm. And in some children, it was actually in the trial particularly, it was accelerating their deterioration and death. So rather than actually causing you to stop the disease, you were actually accelerating death. And why does that happen? That happens because all these therapies we are doing, ultimately, we're trying to modify the body. And we're trying to modify genetic kind of mutations. And that understanding is slowly increasing over time. So when you hear a research breakthrough happening somewhere in the world, that's always exciting. It might be on mouse models. It might be phase 1 or phase 2 trials very early. But then sometimes you hear about a trial being shut down or saying that, you know, it's not reached its desired outcome. And that's because something has gone wrong. And, you know, either a patient has died from that or complication has happened. And these things are very, very tricky. And we can't do any of this alone. So even, for example, with our gene therapy trial and in Manchester, which is now a licensed treatment, you know, we have a whole team of people from different specialties to see a child to make sure that they're eligible. So it's not just that you come to see one clinician and they say yes or no. It's a whole group of people. We discuss this internationally then to make sure that globally, if you had traveled to US or Australia or anywhere, that the opinion would be the same. So that reduces that kind of burden of the family needing to travel all around the world. Other kind of problems is, as you've heard, clinical trials. So you've heard about clinical trials, and this is really, really tricky for rare leukodystrophies. So with many, many clinical trials, what you want is what we call the classic phenotype. And many of you with rare leukodystrophies know that your child or your family member may not be in the classical phenotype. And why is it sometimes trials want the classic phenotype? It's because sometimes, for example, the early onset conditions may be the ones that you may make a difference faster with a clinical trial. So if you think like how a drug company wants to, if you've got a condition which can cause early disease as a baby, versus someone who can gradually deteriorate over years and decades, if you have a trial that you can show that a treatment works in a baby who would otherwise die at the age of 5 or 10, and you can show that they've survived, you get your data from a company point of view within 5 to 10 years. So when you do the trial, you give the treatment, you get outcomes within 5 to 10 years, and you can then very quickly global recruit patients and get them into the trial. But what about the patients who are atypical? So the ones who have the same condition, but you're gradually deteriorating, and the parents come to us saying, actually, my child is milder than the severe phenotype. Why can't they get that treatment? And that's because a lot of pharmaceutical trials are designed for that classical phenotype so that you can get the outcome better, and not designed for the atypical leukodystrophies. And that makes it extremely challenging, very frustrating, and a lot of people ask us, you know, why? Because if you think logically, you'd say that my child or adult colleague has got a milder phenotype, so they should benefit from that treatment you're giving to the aggressive form. But because it's not been trialed, because if they had given it to a less known phenotype that is going to deteriorate over 20 years, that company will have to wait 20 to 30 years to get results. And that always is a challenge in trials. And I think that's the biggest problem, and I think it's important to understand as a family why that kind of unusual presentations are very hard for someone to devise a clinical trial for. Doesn't mean it shouldn't happen, but it is always difficult from a pharmaceutical trial perspective of getting the data. And then, of course, with rare leukodystrophies, there are what we call unregulated therapies, which means you may hear of people across the world who try something off the record and say that, I've tried this and it's really worked in my child. But actually that treatment is not licensed. It may cause some side effects, other problems, and there are different approvals across the world, as you may know. What is approved by the MHRA in the UK may not be approved by the FDA, and vice versa. And it's not always that something which is approved easily in one place will be approved somewhere else. And again, having that open communication and discussion is really important. So just last few minutes to try and summarize the kind of challenges. So with rare leukodystrophies, the first challenge is, can you get a diagnosis? Because a lot of patients who come through may not even have a diagnosis. We know that you've got a genetic leukodystrophy, the scan looks very typical, but you don't have one of the common leukodystrophies, meaning that one of the many ones I've showed you there. But that doesn't mean you don't have a leukodystrophy, and that can be a challenge because you don't even know what your family member has, and that becomes very, very tricky. And then, if you have a diagnosis of leukodystrophy, the sad truth is that the majority of leukodystrophies currently don't have a definitive treatment option. Some of them may do, some of them have very strict criteria by age, and sometimes you may be diagnosed before you can start the treatment. So you're waiting for the child to turn a particular age before you can access therapy. And you feel that you are in this waiting game and that your child may deteriorate or change before that. And clinicians feel frustrated as well because we feel that, if we could give that treatment, that may help. But sometimes you have to wait until a set criteria on licensing. And then I've told you already that, with early phase trials, that may be very restricted. Sometimes trials are opening up globally, and they may open globally, but some trials, especially, if it's very new, phase 1, phase 2, may only be able, for example, to treat one patient at a time. And therefore, they may give one patient gene therapy and see what happens over the next 12 weeks. And then if that child doesn't have side effects, then they take another child. So if you've got 3 or 4 patients in the world diagnosed in that few months, it's very frustrating. And you are like waiting to see who is going to get selected. And these things are obviously very scary, frustrating, annoying for us working in rare diseases, for parents and family members saying, who is going to get it. It's like a lottery ticket. And those things are scary. So despite there being a lot of promises coming, we have to be, very much aware that we have to support each other, us supporting you as family members, and Alex DLC supporting you through this journey. And increasingly, like the case examples I gave you, the first case, that access to compassionate therapy is now starting to become a thing as well. And that may be crossing international boundaries again, that you may need to travel somewhere, and with compassionate therapy, sometimes we may have to see where the funding may come for you to travel. So sometimes families are raising funds for this. Alex DLC may help you with that. So if you are told about something related to compassionate therapy, please make sure you reach out to Alex DLC and let us know if you're struggling, because usually the drug is free, but the travel is what you would need to do. You need to travel to another country, get assessed, and then get the drug, and then have the monitoring. And then, like I've given you an example, could novel therapies be harmful? And it's always exciting when new things are coming. We all get very excited when we see mouse model trials. Yesterday we had a scientific day, lots of promise from our scientists who are working very hard in the laboratories to see what can happen. But the reality is that, mouse models are not children at the end of the day. And a lot of things we may feel that we could translate, but sometimes we try things on humans and they don't go right. The problem with leukodystrophies is leukodystrophies are commoner in children than adults, not like many other things. So with many other things, like, for example, multiple sclerosis, we feel comfortable because these drugs are tried and tested in adults. So if there's a problem in adults, we know about it and we're like, we're not going to use that in children. Problem with this is these conditions are commoner in children. So therefore, after going for mice, we have to try them in children who might be babies. You know, as the first people in the world, first humans in the world suddenly are babies and not adults anymore. And that's scary, you know, and if you are in that situation where you are recruited to an international trial and you are the first human in the world going to get that, that is a very scary feeling. And, you know, you're not sure. And everyone will tell you about, you know, wow, this is exciting times, but families are scared. And, you know, I'm sure, you know, if you were in that situation, you would have that excitement, but the fear of what happens if something goes wrong. So we have to be aware, and we really need to support each other through that journey, because every child is different, and the same for getting therapy, and the same for the condition itself. As I told you, two children with the same genetic mutation could be very different and have very different kind of presentations, and that is perplexing for us as clinicians, because I could see someone and I say, oh, this is another one of those conditions, and then they walk through the clinic room and you see them and you go like, oh, that is not what I was expecting. And that's quite scary for the family, because they just be like, oh, well, so you've not seen this form before? And we'd be like, no. But we have to be frank and open, because actually that's what it is like in leukodystrophies all over the world. And when you link up with other families across the world, then you start seeing similarities. That's when we start pooling our data, collaborating, and publishing. This is really a big thing. It really should be right at the top, but I put it here because a lot of times we are trying to chase what is out there as a definitive treatment, whilst a lot of people forget the basic symptom management. And that actually, that is what living with leukodystrophy is, that you will have some symptoms when you present with the leukodystrophy, and that could be anything from mobility to feeding to speech to access to therapy, and it's really important that we don't forget that, because even if there is any therapy which you can access, this is probably the most important thing to go hand in hand with therapy. You will see that with many gene therapy programs, the exciting stuff that is happening in leukodystrophy, it is followed by intensive therapy. Because without that intensive therapy, if you do any treatment, you may still not make a big difference. So that intensive therapy and making sure that we don't forget the basics of leukodystrophy is really, really helpful. And then I don't need to tell most of you in the room, because we actually don't know how bad this could be for you as a family. And you know, this is of course something that, you know, a lot of you tell us about the struggles that you have, and sometimes it's really harrowing for us to hear the experiences you have, the struggles you have had to fight to come and see us as a specialist team, and you know, how the care is not joined up. And that's a recurrent thing that we hear, is that, you know, you're under multiple specialties, you see 10 different doctors, and then you come to see us finally and say that, you know, you're struggling with all these appointments, with all the struggles that you've got. And I think that's really important that we need to bear in mind. And last few slides to show you is that this is the reality. So many times with leukodystrophy, sometimes you hear the story about one sibling sort of almost saving the other sibling's life. And that's been the case for metachromatic leukodystrophy. We see this commonly in the UK because there is no newborn screening for leukodystrophies in the UK at the moment, and that is challenging, because that means many times it's having a child who's already too late to get treatment, saving another child's life. And I think this is where we are with leukodystrophy now. We are in an exciting time, of course, where, you know, we are understanding leukodystrophies better. So with the advance of genetics, many people are getting a diagnosis much more than before. Lots of research is going into leukodystrophy, so trials are just exponentially increasing that we can't keep up with. So every time I go onto a website called Clinical Trials, before I see a patient come into clinic and put something in, I'm just like, oh wow, there's something else going on somewhere else in the world. And what we would then do is contact them and find out. So that's how we work as rare disease clinicians. We speak to each other, just even have a WhatsApp group where we say, we've got this complex patient. Anyone have any ideas, you know, with this leukodystrophy? Anyone have any trials they know is open anywhere? And I think that's really important, that we network and collaborate all the time. And then exciting kind of things like gene therapy is probably the future of leukodystrophy, but with that caveat that I told you, that it's very challenging in children being the first people tested. And then finally, newborn screening. A lot of us are pushing for newborn screening in leukodystrophies, and I think that is going to be the way forward for us to really understand this better and try to make a difference. But again, we have to make sure that we've got something to offer before we just do blanket newborn screening for all kind of leukodystrophies. So in summary, I think I've told you many times that the symptom management is probably the most important thing in leukodystrophy we should not forget. There are lots of trials and treatment options starting to come now in leukodystrophies compared to 10 years ago, and most of them will involve international travel because we are really collaborating internationally with this. We are trying very hard to be a site for many different things when things open globally, but sometimes in very early phases, it will be very international. That wide spectrum where you see two children across the world presenting differently is increasingly common now, and that's very challenging to understand, and that's why the database is really, really helpful. And like I told you, the referral, we are really trying to get that awareness up amongst GPs, general pediatricians, community pediatricians to say that actually referring to the inherited white matter disease hub, even if you have a diagnosis already, is helpful because it's not about giving you a diagnosis, it's just supporting you through that journey, making sure we coordinate your care, which might be very disjointed, and if a potential treatment option comes, we'll probably be the first to hear and be able to link families and the main site delivering the treatment very quickly. And on that note, I'll end. I'm happy to take questions. Thank you.
Okay, as I'm sure you're all aware, I'll be putting up Slido. If you have any questions, please just raise your hand. Ingrid will hand a microphone to you, and Dipak can answer any questions you've got. Okay. Does anyone have any questions? No? Yeah? Just a sec.
You know, is it on?
Yes.
Yes.
Yeah. Do you know you said about how children can have the same condition but be different? Well, I've got two sons. My younger one was diagnosed with ALD at age 6 and he died when he was 7. My older son was diagnosed at the age of 10 and he's now 35. And they presented so differently. My son now, he's got learning difficulties, he's registered blind, he's got bladder problems, but other than that, he's perfect. As I say, my younger son went he went into hospital and they said he had a virus, but he didn't, he had ALD, but they didn't know then. He went from being perfectly normal to not walking, not talking, not being able to go to the toilet, not eating anything. So, and it was horrible. And it was in 2001, so there wasn't a lot known about it by then. It was like, I didn't have anyone to talk to at all. And then I was looking in Woman's Own magazine once, and there was a story about Sarah had put a story in there about it in the charity. So I got in touch with her, and then all been good since then.
Excellent. That's really nice to hear that you had the support. And scary when you see two children presenting very differently. And I think that's the thing that in these rare diseases, we're still trying to understand what makes it different. But it's really hard to understand because that is increasingly common now that we see any gene, like that, the way it manifests in children and in adults can be very different and such different kind of, presentations. Thank you for that.
Any other questions? And in the meantime, if you have any comments on Dipak's presentation.
Right
Yeah, Ingrid in the back.
Thanks, Dipak. Just wondering, any reflections or recommendations? So obviously these are very rare conditions, and getting the referral to a specialist centre such as Manchester. Could you comment on kind of medical education and general awareness, maybe around paediatricians, GPs, what kind of things can be done to kind of increase the awareness and the sense of urgency for referral?
Yeah, definitely. Thank you. So we are doing a lot of work, across the UK, and then in the north, myself and Lydia, we do an annual study day, alternating between Leeds and Manchester for pediatricians, generalists, community pediatricians, specialist nurses, to talk about these rare diseases, why it's so important to refer. And I think this is a work in progress. I think genuinely it will take about 5 to 10 years for that understanding to really increase amongst all pediatricians, because there is still that notion that for many conditions, not just for leukodystrophies, that if someone is looking after a patient, they'll be like, why do I need to refer because there is no treatment? And that is something we are really trying to change, not just for leukodystrophy, but for all conditions. Because it's not to say that we are taking over the care because someone else can't manage it, but it's just to offer, exactly like you said, that holistic support, the specialist nurse access, access to LXDLC, and all these kind of things that we can signpost the family to. And that is something we're trying to break through, that barriers with, like, pediatricians, neurologists. I think things are changing. I have to say, in the first year of the service, we were getting very few referrals, particularly in the north, and now the referrals are increasing. So I think it will change over time.
Any last questions before we go? Yeah?
The new buzzword is AI and how AI is supporting medical communities in general. Do you see AI being used as a future tool? Yeah. Do you see AI being used as a future tool in order to progress and accelerate research, diagnosis?
Yeah, and I think there is a lot of work like, our research colleagues are doing with AI, and I think, of course, with everything, even like with gene therapy, there's the pros and the cons, and I think with AI as well, it's just how it's used. Certainly in radiology, there is a lot of now research going on. Our radiology colleagues in Manchester in the university are doing a lot of research into AI, for example, for pattern recognition. Can you look at the scan and pick out some leukodystrophies? You would still, of course, need the human factors there and someone to look at the scan, but that is something exciting that they're doing to try and say, if a scan goes through, can AI look at it and try and pick up, not just for leukodystrophies, but even for other things. Can it say this might be a tumor, this might be things, and it might give you some differentials. But of course, there will be some limitations to that, particularly with understanding genetic kind of disorders. So AI might give you a list of things which say, these are the conditions to think about, and you might do genetic testing and you don't find it. But very frequently in this leukodystrophy service, that's what we see. We have seen many between me and Lydia where over the years, they come to our service with no diagnosis. And we look at the scan and say, actually, we know what the diagnosis is, and the genetics were negative. And we have to go back and say to the geneticist, have you looked at that gene more carefully? And they look at that gene and they find the mistake. But if that just went through AI, it'll just say, yep, no, you're fine, no genetic diagnosis. So all these things might help, but we have to be very careful that we still have a whole group of people helping to look at what AI is figuring it out for us. But I think that there will be a role for sure.
Did I mean to replace you? Just like accelerate?
No, but definitely, yes. We definitely need help to make things quicker. Yeah.
Okay. Thank you guys so much.